All right, well, welcome everybody. This is the second session this evening, so thanks for bearing with us. This is the information session for the Directors of Paediatric Education regarding the divisional clinical examination. Next slide, please. So I apologise, my dog is barking. Firstly, I'd like to acknowledge the traditional owners of the land on which we meet. For me, it is the Wurundjeri people of the Kulin Nation, and we would like to acknowledge the elders past, present and emerging, and we would like to state our intent to look after the educational the education of the traditional owners and the Maori people from which we work. So if we can, I'm sure we all will thank everyone for that. If we could move on with the next slide. I'm sorry, I've lost my prompt. So obviously many of you have heard this bit already, but the purpose of the divisional clinical examination is to assess the clinical skills, the acumen and interpersonal skills to inform whether our trainees have reached the standard for completion of basic physician training. Next slide, please. Our key dates are the exam results are released on the 13th of March. So our trainees are all nervously awaiting their results. And once they are aware whether they are going to be eligible to sit, the applications open for Australia on the 14th of March and close on the 20th of March. And that tight window is so that people can so the people at the assessment services can do the travel allocations. The exams, as you would be aware, are the 16th of May through to Sunday the 1st of June, and the results will be released on the 16th, the week of the 16th of June. We've got important point there about the pre-examination. You can submit an application for special consideration with supporting documentation at the time of registration. So those type of things, as we've alluded to already, are hearing impairment. You may require specific medications. You may there may be a specific religious or cultural event that you wish to participate in, and so perhaps we may be able to schedule your exam around that. Or if there are any specific medical conditions or pregnancy that we can work around. So the post-examination special considerations we'll also talk to a little bit more in detail, but essentially these are events that occur on the day of the exam, so procedural incidents or a technical issue. So we're not talking about the fact that there was a MET call in the middle of the in the hospital itself and the candidate heard that overhead. That's what we would deem not significant. However, we had a candidate a couple of years ago who fell over in the lunch break and actually ended up spending her lunch break in the emergency department and was fitted with a cam boot. And so that candidate put a special consideration in and they were offered a supplementary examination. So they're those kind of very extreme but extenuating circumstances where we can look at whether that adversely impacted the candidate. Next slide, please. So the terms and conditions. So all of the candidates need to be aware of the terms and conditions when they sign up to do the exam. So they must agree that they will raise procedural incidents with the LEO, the examiners when they're presenting, the chief examiner or RACP staff that's in Aotearoa, New Zealand on the day of the exam. And the candidates must acknowledge that they have read the special consideration for assessment policy. So we want the candidates to be very aware that they must be physically and mentally prepared and well and in the right situation to sit the exam. And so over the last couple of years, we've had a number of candidates who have been unsuccessful writing for special consideration and asking that their exam result be reviewed based on the fact that they had a run of nights prior to their exam, or that they had been unduly stressed with the lead up to the exam, or they'd had a medical condition that had not been well managed. All of those situations, we need you as DPEs to be involved as well, and to really sit with those trainees that you feel may not be ready and have an honest conversation with them. Because if your trainee is not ready, then, and they sit on the day of the exam, that is counted as an exam attempt. If your trainee is feeling that they are not ready, or their physical or mental health is not at the point that they feel they are well enough to sit, then they can withdraw and get a 50% rebate 4 weeks before the exam. But even up to the day before the exam, it is possible to withdraw. And for that candidate, that may be the right thing to do, because they don't want to have that attempt counted again. In years gone by, there were more attempts, and now they've got 3. So I think it's something that we should be quite honest with the trainee and be aware that, yes, it's going to be an uncomfortable conversation, but for their benefit, it is a good thing to do. Drogo mentioned in the last session that even on the day of the exam, if you're not feeling, like if you see a candidate and they're not looking great, it may be worth a discussion with them on the day. Anything to add there, Drogo?
No, I think you've covered that really, really well. And I think we've had a good chat with the Leos as well, to keep an eye out for candidates on their morning and, just touch base with them. I think we want this to be a kind exam. We want this to be a good experience. We don't want people to be traumatized from this. And these are kind of really important comments that are really coming back to us as the heads of the committee, and also back to the college as well. So I think we need to have the trainees' well-being and foremost in our minds as they go through this, and give them the best chance possible of passing these exams. We've all of us as DPEs have seen candidates who have gone in unprepared and have predictably failed, and then found that really difficult to get over. So I think, yeah, the onus is on us as DPEs to make sure that we're doing the right thing by our candidates. Yeah.
Yep, great, thank you. Next slide, please. So the academic integrity, we obviously want to maintain this highly. So this is the candidate participation agreement that the Leos will ensure the candidates will sign this on the day. The candidates must uphold and adhere to all examination rules. Any academic misconduct will be handled consistently, openly, justly, and fairly through an appropriate process. And it's there to prevent any candidate from gaining an unfair or dishonest advantage. So the candidate participation agreement is, as you can see there, and there's a hyperlink there. Next slide, please. So we've really touched on this, but it's the role of the DPE to provide pastoral support and to remind candidates to assess their readiness before sitting the clinical exam. The candidates who are unsure of their options can contact the assessment services. And so, that's things around if there are financial hardship that can be discussed with the college. If the candidate really feels unprepared to meet the required standard, withdrawal is strongly recommended. I mean, I think we've probably all had candidates in the past who've like, look, I'll give it a crack, I'll see what happens. But if there is a vulnerability in that trainee or there is a specific illness, I think it's worth encouraging that withdrawal. And so, as we've alluded to, that the exam attempt will count if they actually sit that exam. So there will be no special considerations for those trainees who've attempted the exam with inadequate preparation, who have had lots of work commitments or stress related to the exam. It doesn't fulfil the special consideration assessment policy. So I think it's really important that the DPEs are across that. Next slide, please. So exam preparation and support, there's lots of information out there. The candidates, we would encourage the candidates to look at the exam format, the timetables and the expectation on the website to prepare them for the exam. There's the RACP online learning resources, including the Divisional Examination Readiness course. So those links are provided in the candidate allocation emails. And there is the RACP support program offering 24/7 confidential assistance through Converge International, and that is free to fellows and trainees for support before or after the exam. And that's a useful resource for those candidates who need it. Next slide, please. So candidate allocations, I think it's really important that people understand how this happens. So those candidates with pre-exam special considerations are allocated first. So if we have a candidate who's 38 weeks pregnant around the time of the exam, it may be that that candidate is allowed to sit intrastate, but away from sites that they have worked. We allocate candidates with pre-existing complex requirements and then allocate the re-sitting candidates as well to ensure that they do not sit at a site they've been at previously and ideally not with similar examiners, but that can't always be the case. And then all of the remaining candidates. So the travel considerations, candidates are allocated to states they have not previously attempted the exam, trained or worked. We spread candidates out from the same hospital network to ensure that the medical workforce unit actually has a workforce to cover the service during the exam cycle. And metropolitan candidates should be allocated to regional and rural sites and vice versa where possible. And ideally, we're not going to be sending people from far north Queensland to Western Australia because obviously that is a very, one, lengthy trip, but two, a very expensive trip for candidates, and that is a consideration for them. What I have told my own trainees is that they are typically allocated to a state and territory that's not their own, and they should be prepared to travel. Next slide, please. Withdrawals and refunds. So withdrawing from the exam does not count as an attempt, and there is a college fees terms and conditions which goes through the amount of time that you can withdraw from the exam and receive a 50% refund, but if it is less than 4 weeks before the exam, there is no refund. There is a medical and compassionate ground, so and that may be requested by submitting the application form under the special consideration policy. The withdrawal process is an email to the DCE team at racp.edu.au, and the written notice must be received before the application closing date and approved by RACP for a refund. You can't hold that money in credit for next time, and those that fail to appear for the exam will forfeit all fees. Next slide, please. So, examination development. So, obviously, there's been a recent review of the New Zealand ARTIA exam process from 2021, which has implications for our exam. So, obviously, it's conducted in a clinical environment with real patients requiring extensive preparation for fair and consistent assessment. We've spoken to the LEOs today about identifying and recruiting suitable patients based on the assessment blueprint, which is a key focus. And we're having significant examiner training, calibrating and coordinating a large cohort of volunteer examiners to maintain integrity and consistency. And the college is going to be, for the national examiners, we're going to be having a 2-hour unconscious bias session at the National Calibration in Sydney this year. We also, and I'm sure many of you do this with your trainees, go through the marking rubric for the long and the short cases, and making sure that the candidates are aware of where the weighting is for the long and the short cases. And we also reinforce the expected clinical performance and decision-making standards throughout the exam process. So, you know, as a local examiner, I still remember thinking, gosh, you know, the national examiner, wow, they're pretty lenient, but actually, no, they're not. It's actually, we're marking these candidates at the level of a third-year trainee. It's not somebody who's been as a consultant for 20 years. So I think, you know, ensuring that is the standard is a really important point. Next slide, please.
Might just jump in very quickly about the patient recruitment, Nadine. And like, I think we talked a lot about that with the LEOs. I personally feel it's a really big responsibility to put on the LEOs to get that balance right. And I think as DPEs and people who are the lead local examiner for your site, it's really important that you work hand in hand with your LEO to make sure that that happens. You know, if as a DP, if you're an examiner, then you've got even more knowledge and insight into the process than they will have. Remembering a lot of the LEOs are just, you know, probably in their second to last or last year of their advanced training. Their experience of the exam was the exam day they went through. So I think it's really important that we really, really engage with them and make sure we get that right. I don't think the LEO should be doing that particular task on their own at all. I just want to kind of emphasize that, Nadine, and yeah. Yeah,
that's a really good point. Thank you for that. Okay, moving on. So we use the scoring rubric, or the CLEAR 6-level performance scale for both the long and the short cases. And then we use the case type scoring grid, which obviously you can find on the website, which looks at the intersection of bands from the long and the two long cases, and then works out exactly how many short cases you need to pass with a aggregate score to achieve a pass mark. So I think we all feel that that has overall competence and allows for minor variations in individual case performance, and I think it proves that it's pretty well validated, actually. So we've talked about examiner calibration, and us as national examiners do calibration at a national level, and many of us run the local calibration sessions as well. So I think having that national examiner as setting the standard is really the key point for our exam. I think enhancing transparency, and certainly we have been talking to our candidates about what is expected, getting them to look at the rubric, and ensuring they understand what the grid looks like and how the scoring occurs so that they can achieve a pass. I think that is very helpful to them, understanding that there are no secrets towards this. Evidence-based standard setting processes ensure reliability, consistency and fairness in candidate assessments. And I think we've already alluded to all of that with our marking rubrics and our calibrations. So next slide, thanks. You will all be aware of the examination timings with the 2 long cases and the 4 short cases, and obviously our examination teams of a NEP or SEP, a local examiner, and hopefully we have lots of new consultants coming through who will make excellent provisional examiners, so that we can ensure that we have more people coming through to help with the standard setting. Next slide, please. Again, we've got these very busy slides coming along with the long case schedule first. Next slide, please. And the short case first. So you can look at these yourselves, and I'm sure that you're probably quite familiar with them, but those starting on the long will also end on the long. Those starting on the shorts will also end on the shorts. So next slide, please. So the long case, well, what do we want from the long case? We want accuracy of the history, accuracy of the clinical examination, and where most of the weight is, that we want synthesis and prioritisation of clinical problems and an understanding of the impact of the illness on the patient and the family, and making sure that that trainee is able to develop and discuss an appropriate management plan that is individual to that particular patient. So obviously, we want the patient or the parent to give an adequate history, and there should be some significant physical examinations finding and some current active management issues so that it makes it easy for us as examiners to ask them those questions. And ideally, 2 to 3 major diagnoses, often with added psychosocial factors, have a bearing on management. And 1 complex medical and 1 complex neurodevelopmental case is ideal. And this is where you can help your Leo in choosing these cases. The candidates, as we've said, need to take a comprehensive history and perform an accurate physical examination. It's critical that they identify the current clinical management issues and prioritise and discuss them appropriately. And that's what we really look at as examiners. Next slide, please. The short case, obviously, we want to see how they interact with the patient and the family. We look at their technique, how accurate they are, and again, the interpretation and synthesis of physical findings and investigations and management as appropriate to that particular case. Again, this is where you can support your Leo to make sure that the families, when they're recruiting them, are going to be seen by five sets of people, so the examiners and then the 4 candidates. And it's best if you have a cardiovascular, neurological, an abdominal or gastroenterological case, but then something else like a short stature, developmental, or a lower limb or gait exam. Ideally, the candidates should have at least 1 good clinical sign, which a discussion takes place around, and you can then discuss with them about their investigations. And really, you know, I've said to my own candidates, it's not about getting a spot diagnosis. It's not about having minute detail. It's actually about how good their reasoning is to put those signs together, and then question whether that's an appropriate differential. The patients are usually cold, so that's usually meaning that there may be a valvular heart disease or a repaired cardiac condition, something that's static and will stay, rather than somebody with a pneumonia that you saw 3 weeks ago and which is subsequently resolved. Next slide, please.
Might jump in very quickly. The number of times that we've had a short stature that's no longer a short stature, and no one's bothered to check because they've gone on growth hormone or something like that, and that's tripped up a few short cases and a few Leos when they've turned up to the assessment. You can't look at if they were used a couple of years ago and predict that that's going to be what they're going to be like on the exam day. So always double, triple check to make sure those signs are still there.
That's excellent advice. Yes. So expectations. So candidates must be present outside the long case presentation room by the start of the session. We're not going to wait for you because obviously we can't, because the timings are so tight on the day. Candidates should not expect the full 10 minutes for long case planning. We talked about transit times around the clinic. Just the way your clinic's set up, it may not be possible for you to get all of that 10 minutes. And the medication lists are a guide only and may not reflect recent changes. So we suggest to all the candidates that they check with the carers that they are the appropriate medications. And oxygen saturations will not be provided for any cases. And so candidates, if they ask for vital signs, it's what they can measure themselves.
And
Thank you.
just on that topic, I think we've tried to make it as clear as possible this year, but we try to make it clear in previous years as well. But it's one of the most annoying things is when they always ask oxygen saturations when they know that we're not going to give it to them. So maybe just tell your trainees when you're doing your short cases, just don't ask for oxygen saturations, just go and assess their colour and what they feel, whether they're cyanosed or not, or what they'll do.
Yeah, absolutely. Next slide, please. So for patients, we are so grateful to our volunteers. They are a vulnerable group of people, and they may experience fatigue and stress during the 4-hour examination process. And so obviously we all get to the point where we've had enough, and we might get a little bit teary and emotional. And if that's the case, you know, what we assess our candidates on is showing empathy and acknowledging that this is a diverse cohort of patients, and this is real work. This is reflective of what we do every day. And I do tell my trainees that how you manage that situation is actually a reflection of how you are as a clinician. So I think that's a really important point to let the candidates know. The marking process and procedures are standardised. So if somebody does have a meltdown or lose it, then and patient interactions, that kind of thing, that doesn't qualify as a technical or a procedural incident under the special considerations of policy. So, you know, we would be looking at things like a patient having a prolonged seizure for 20 minutes, or those are the significant procedural things that would constitute that, and we would look at that when we're looking at the marking of the patient, of the candidate. Next slide, please.
Just on that last point, you know, as the NEPs and the SEPs, you know, we talk amongst ourselves and we bring it up at calibration. I think most of the time is, you know, making sure that when those things happen, that we always take those things into account. And that's been our general philosophy for as long as I've been a NEP for as well, that, you know, if the child just loses it for a particular short case, that you generally do take that into account. And we do have sessions on how to adjust your short case to get allow the candidate to get the most out of that particular session. So.
Please, next slide. Dress code. So obviously we want everybody to be comfortable and bare below the elbows. So thanks to COVID, we had the joy of scrubs, which are all lovely and can be really child-friendly. However, no hospital logos, and we also ask no suits, ties or jackets while examining patients. And digital watches or analog watches are fine as long as they don't have smart watch capabilities. Certainly in my hospital, we would be fine with a watch with examining a patient during the clinical examination, but obviously be guided by your own local policies. For candidates, their mobile phones can be accessed during lunch breaks, but do need to be handed in to the LEO at the start of the day and then given to them at the start of the afternoon session. The candidates also need to bring their candidate allocation email and photo ID. They are allowed personal stationery and their own stethoscope and their exam bag, which the list of items is on the website as well. And to save the number of pre-exam special considerations, they are also allowed to bring water in a transparent unlabeled bottle, and quiet food, so some sweets which are not crunchy and not distracting to anybody else. So in a clear container and consumed between cases. Equally, some personal medication must be in a labelled Ziploc bag with name and candidate number and kept with you at all times. We've talked about the exam bag, which all of us know that all of the candidates have a wonderful time heading down to Big W or Kmart and filling up full of toys. It's always part of the joy of once you get your written exam results. And obviously stethoscope, your usual things such as tuning forks and props, tape measure, but the LEOs should be directed to having like a developmental kit if you have a developmental case, so that the examiners don't have to bring their own. Next slide, please. And that looks like it. So questions from anyone?
Well, probably one little comment from me is that I think candidates need to be prepared to manage their timing themselves. That means, you know, if they're going to have a watch or some sort of thing, working out how to use that and making sure that they can use it without it being on their wrist in case the hospital has a bare below the elbows policy that they're going to enforce. I think it's really clear. We've had some discussions within the committee about examiner assistants holding timers and things like that. I think that is no longer allowed, and they need to be aware that that's the case. So if there's a timer that they want to use, they need to put it somewhere that they can see it in the room, or have some sort of wristwatch or watch that they can use, whether it's a little pocket watch or something they can pull out to keep a watch on the time. Remembering that the examiners, we will keep a watch on the time as well, and so we will always be there guiding them through that. So that's just another little thing I just wanted to mention. I think it's really important that the candidates are aware of that, and that as DPEs that we tell them that through their preparation time.
It turns out that we've had a technical glitch, and actually I think we're only halfway through the slide, so we might continue. Sorry. Are we having technical issues? Can I put it in special consideration for me?
You get to do it all over again, Nadine. There we go.
Great. Okay, so the medication list, it's going to be taped down to the desk in the long case room, and we will get 2 copies of that for the candidate. And also remembering to tell your candidates that the medication list is a guide only. It may have changed since the patient's last outpatient appointment, and to check with the patient or the carer who is there. So examination assistants, and, you know, we've had lots of discussion about this in the committee, but we feel that the examination assistants, they do really benefit from seeing what happens during an exam day, so for their own personal preparation in coming years. Their role is really, in old school parlance, to be seen and not heard, I guess. And they are there to escort the trainees around the clinical exam sites, because hopefully that will be their home hospital and they're aware of where to go. But what we don't want them to do is to be involved in the actual exam, and you may have heard me talk about this, but actually interfering with the timing and the assessment is very challenging for us as examiners. You know, when you've got bulldogs or examination assistants putting the timer in the face of the candidate so that they can see where they're up to, but actually the examiner can't see what's happening, so they can't assess the candidate properly. They should also be very neutral in terms of their interactions with the candidates. You know, they shouldn't say, oh, that examiner was rolling his eyes in that particular assessment. So, you know, things like that are not helpful to anybody, and equally as examiners, we should never be doing that. But, you know, in years gone by, you know, we've had feedback that that's happened, and the examination assistant has said those kind of things, which can negatively impact the candidate. Equally, we want the candidate to request the specific equipment that they need. So we want them to ask for the tendon hammer, not have it proffered by the exam assistant. Next slide, please. So we've spoken about this actually with the score combination grid. Replacing the traditional weighted scoring, and it allows a strong short case performance to balance a lower long case score and vice versa, except where both long cases are below the minimum standard. So it reduces from examiner leniency and minimises false positives or false negative outcomes. And the system was rigorously validated through data simulations, trials, and parallel testing, and it showed 89% agreement with previous pass rates and only a 1.6% adjustment to overall pass rates. So it's a confirmed, validated and reliable evaluation, and the college formally adopted it in 2019 to ensure that the candidates assessed consistently within the established performance criteria. And the score combination grid is available for the candidates to review online, and at our recent boot camp, I took our candidates in Victoria through it so that they are aware, so that there should be no surprises when they're thinking about the marking. And as you can see there, the long cases determine the band, and then the short case performance determines if the standard is met. So there's obviously the aggregate scores and the number of cases passed depending on the band. So the results process, what we go through is that we enter the data, so the scores are submitted into the digital score sheet. There is checking for anomalies and data comparison. Then there is the RACP exam analysis, which is reviewed by the senior lead, assessment and data analyst. And then us as the committee sit in the results meeting. The documents are well prepared by the assessment services, and thank you for that. And they are updated with the special considerations, and if there are any particular cases that a procedural incident occurred, and then we have a discussion about those incidents and consideration of whether a supplementary is warranted or if that exam attempt does not count. We then have a confirmation of the exam results. So the committee officially confirms the results that we have verified, and those then go to the administration of results for final preparation and then re-review before release. And they are typically released midweek to ensure that candidates are able to access somebody at their site, such as their DPE or local examiners, so that they can get support should the outcome be negative. Next slide.
Might maybe make a comment, probably more about the slide before the last one, that, you know, we have all, I think most people here and on the committee have had candidates who have been in band 5 and who have failed the exam because they haven't passed a single short case. Mm-hmm. So I think it's important that we make sure that we emphasize to trainees that they need to work on both long cases and short cases. The emphasis has been much greater on short cases over the last few years, not long cases, sorry. So they do generally do a lot better in long cases than they do in short cases. So making sure that candidates know, yes, even though you're a gun at long cases, you still got to pass at least one short case.
Yeah, that's a really good point. And once we have looked through all of the marks and looked to see if there are special considerations, the marks are never going to be changed after the exam results are released. we will not rescore or reassess, and a candidate cannot be granted a pass based solely on a special consideration. They would have to then redo the exam, either as a supplementary or the following year if they have exam attempts left. So feedback has been an issue, and we are constantly trying to improve the feedback that candidates get. The digital score sheet has been life-changing for many of us because, one, we don't have to rely on our handwriting, but equally it means that the candidates are able to get a legible and useful document. The successful candidates are provided with a results letter, a feedback document, and a reflection sheet for self-assessment. But those unsuccessful candidates are offered a session with a national examining panel member in their locale to provide in-depth feedback and support. And the feedback document is provided to the candidate at the end of the feedback session. As I said, it is based on geographical convenience as to where the national examiner and the trainee meet, and they can also have a support person to attend the feedback session with them. The DPEs receive results summaries for all candidates in their jurisdiction to help guide future exam attempts. So while the support from a DPE is really important, it's hard to, you can't really suggest that that feedback or the marks are incorrect because you don't know what happened in that particular case, and you need to rely on the fact that your national examiner and the local examiner in that site were doing the very best and trying to be as honest with their feedback as possible. So the special consideration for assessment. So again, I think we've talked a lot about this, but it allows for special consideration and arrangement for assessments in all RACP training programs and reasonable adjustments for candidates with permanent or temporary circumstances that may affect their performance, such as hearing impairment needing an augmented stethoscope. It allows equitable access to assessments and examinations, aligning with the anti-discrimination legislation and the RACP's commitment to supporting all trainees. Next slide. So, as I said, we've been through a lot of this, but the things are permanent or temporary disabilities, pregnancy and breastfeeding needs, non-medical compassionate grounds, or serious disruptions. So, such as the death of a spouse, I would imagine, in that particular case before the exam. Essential commitments, so religious, cultural, societal events or legal obligations, or technical issues encountered during an examination, so such as a prolonged seizure of a child. Those that are not eligible for special consideration, so failure to meet the RACP assessment standards, late examination applications, so popping a request in on the 22nd of March will not be accepted. If you have already exhausted your examination attempts, so if you've got 3 attempts and you're no longer eligible to sit, or you've exceeded the time limits for training completion, or late training application. So, oops, I've got to put my annual application in. So, as a committee, we talk through these special considerations. They may be granted, partially granted, or denied. And if partially granted, alternative arrangements may be offered. So if they are granted, you still have to meet the RACP requirements. You won't get a lowered mark because of that, and all results are final. The arrangements only apply to the specific exam for which they were approved. So if you had one application for 2024, you need to reapply for 2025. So the reasons for denial of an application include incomplete application, missed deadlines, insufficient evidence, or late submissions, failure to respond to RACP requests, and requests that cannot be accommodated or non-compliance with the policy. So that's why we've really harped on about the policy, because, you know, trainees will ask you as the DPEs, you know, should I put a special con in and see what happens? So I think, you know, if you can honestly tell them, no, that will not be accepted, I think that improves the long-term outlook for that particular person. Next slide, please. So again, we've talked through this. Things like a candidate had recently had knee surgery and was unable to bend down. So we knew who that candidate was, and we were able to accommodate them with regard to some of the examinations that they were doing, and made alternative arrangements for them. Carry food or medication, use of aids or equipment, access to a private space for breastfeeding or expressing, or there is specific allocation during an exam cycle, and withdrawal without financial penalties. So it's what can be reasonably available in an RACP trainee's workplace, such as special equipment or assessment modifications. But some, you know, in some exams, it's just not possible to be accommodated. And so things like extra time, because I have to feed the baby, it's impossible for us to change the timing for that particular candidate. During the examination, it refers to the technical or procedural issues encountered, and the candidates must immediately inform the examiner if a technical or procedural issue occurred during an examination, and where possible, the issue will be resolved during the assessment, and or appropriate compensation will be provided. So, you know, if the child who's had the prolonged seizure for 20 minutes and or mum's had to change the child and it's taken quite a lot of time, they've missed a chunk of time, then that will be accounted for, and it will be reviewed, certainly in the results meeting. So post-assessment, again, incidents or issues that occur after the examination has commenced and cannot be resolved or compensated during the assessment. So that basically is things that we will review, such as our trainee who broke their ankle during the lunch break, where we were able to then look at whether that was an attempt for that trainee, or whether they should be offered a supplementary. And in that case, there was offering of a supplementary examination. So the special considerations don't result in extra marks or a result reset designation. So it really is either going to be a non-attempt, supplementary, or a partial refund of examination fee. So the exams will not be rescored, reassessed, or granted a pass in line with the special consideration assessment policy. And these are the things that we don't consider an appropriate for a special consideration. So routine stress, we're all stressed and it's a challenging time for everyone. Personal or social commitments, including travel, weddings, community events, or financial hardship alone. Minor illnesses or non-acute conditions affecting the candidate or close family, stress related to travel arrangements made by the candidate, misreading exam instructions, forgetting deadlines, losing study materials, or attempting an exam without adequate preparation, minor disruptions such as hospital announcements or incidental noise from staff entering the room, or technical issues before the exams start, provided they don't impact the actual examination process. Sorry, you need to use the official application form and submit as early as possible, but no later than the published deadline. So to Appendix A of the policy, and you need to provide as much supporting evidence as possible. As the committee members, we don't know who the candidates are, and it's only reviewed by relevant college staff and committee members to determine the eligibility. And those late applications are not going to be considered. And the notification of the outcome, applicants will be notified at least 2 business days before the exam for those pre-exam special cons, or within 20 business days of a complete application. I think we've done all of this before. So the outcomes, we've reviewed once all the supporting documentation, and the applicants will be notified with at least 2 business days before the exam. And post-examination applications within 5 days of the exam by email and before the results are released, and they are reviewed during the results meeting with the outcome sent to the candidates at the same time as the results release. So if a special consideration application is unsuccessful, the trainees may request a review through the college reconsideration review and appeals process, and that is a reconsideration, a review, or an appeal can only be initiated after a special consideration has been submitted and it was unsuccessful. And this occurs with the reconsideration review and appeals bylaw to those decisions made by college bodies, and excludes the examination results. And so again, there is a link here for the reconsideration review and appeals bylaw for the process. So that seems to be in quite extreme circumstances. And contingency plans, as we've said, this has obviously been in the wake of COVID, but hopefully we're not going to have a disruption. And if there is, there will be a plan B, and the the impacted candidates may be reallocated to later in the exam cycle. Thank you all for your patience. It's been a very long session. Are there any specific questions from the DPEs? Well, thank you all for attending. I think probably the best thing to say is that if you are able to familiarise yourself with the policy, which we obviously have harped on about, I think it will make your lives as DPEs and your trainees' experience much better. Good luck with preparing for the clinical exam. Thanks, everyone. Take care.